my friend Jennifer has systemic.
Okay.
And
That's a very good question. Yeah.
you know, is there a marker?
Excuse me, folks. I didn't mean to cut you off, but they're trying to record each individual session.
Okay.
So the microphones are actually recording it. It's not going to be projected in the PA.
Okay.
But so as people speak, if you could use the microphone, I appreciate it. That way it can be recorded.
If you don't want your question recorded, just turn it off.
Yeah.
All right, we're fine.
I think it was recorded.
So that's a very good question. So there's no marker.
Okay.
Okay, I'm trying. So
At what point can you, yes, indolent to aggressive?
no, you don't always. So the first thing is there are many patients who stay with indolent or smoldering and never progress to aggressive. Number one. Number two, there's no marker that you can say.
Okay.
There's a lab that you can order. It's symptoms. And so that's when Jason had gone over those C findings. So when the liver gets big enough, or the spleen gets big enough, or the blood counts get low enough, those are symptoms that qualify a patient from indolent to aggressive. Now, there are patients who have aggressive mastocytosis who don't have aggressive enough mastocytosis. In other words, there's those findings. Remember that there was a slide that he made.
Yes.
They're not quite bad enough
Yeah.
or
yeah.
severe enough to qualify for the
Right.
clinical trial.
Right.
And so that's there's a little bit of a fudge factor. But, so not everybody moves on. Some people stay indolent forever, which is good. And the patients who move on, it's all based on clinical findings. And they're very
Okay.
severe. Those
Yeah.
C findings,
Yeah.
the 4 or 5 of them are very, very severe. And there are a lot of patients who don't quite make it.
And those are
So so there's different ones. Low blood counts, big liver, causing symptoms. Big spleen, causing symptoms.
That my friend does too.
Right. It depends on how low, though. There's certain criteria. And then malnutrition, so you're not absorbing, losing weight.
I was trying to stabilize, but I was losing weight.
And there's certain parameters for how much weight you have to have lost in a period of time, things like that.
So if you have, my husband qualified a lot with that, but the only thing is that he already had his spleen removed.
Uh-huh.
So then does that disqualify him?
If that was the only symptom that he was having was an enlarged spleen that was causing problems, and by removing the spleen, that
No,
negated.
Yeah, he had an enlarged liver, and then he had the marrow.
Right. So again, every patient's a little bit different. If the only symptoms were from the spleen and the spleen's no longer there and the symptoms are therefore gone, well, then he wouldn't qualify.
Right.
Yeah. But this is, you have to separate the issue between qualifying for a clinical trial and if the drug is approved, then you make a decision based on, whether the patient would benefit. It's a slope, and so you have to cut the patient. So anybody that's on this side of my hand qualifies. That doesn't mean that patients here wouldn't benefit from this drug.
Dr. Godley listed several treatments.
Right.
So if you try those, and some of those are like chemo,
Some of them are chemo.
and they go by cycle,
Right.
then you can try those, I suppose,
You could.
and then see if they benefit from them.
True. So if you wanted, if the physician and the patient felt that he or she needed therapy but didn't qualify for the clinical trial, then those are options obviously available. It's hard to make a judgment.
Right. It's really based on
But this is the problem with doing clinical trials. One of the problems is you have to arbitrarily make a decision saying that everybody on this side of the line is eligible and everybody on this side of the line is not eligible. That doesn't mean that these patients wouldn't benefit.
That's right.
It's just that you have to arbitrarily say there's a line in the sand for which you have to cross in order to be eligible. And that frustrates a lot of patients. Not just on this study, it frustrates everybody.
Sure. My feeling is my friend is feeling wonderful.
I don't feel bad.
Yeah.
I've got
She feels
enlarged spleen, as the MRI or the CT camera said. You have an enlarged spleen. The doctor feels feeling it, says, yeah, it's
Yeah.
What does an enlarged spleen do?
So
Yeah.
nothing. So as it gets bigger and bigger, if it continues to enlarge, it can cause inability to eat, for example, because it pushes on the
digest,
stomach.
exactly.
As it gets bigger, but it can become severe. Sometimes it gets so big that the blood counts, because the spleen soaks up the blood, the
Yeah.
blood counts will fall.
Yeah.
Those are rare. Those are rare. Yeah, but it needs to be really dramatic. So it may be that your spleen's enlarged, but it's not causing you any problems right now.
So,
Off the chart.
Right.
yeah,
But yeah,
1700.
Something like
yeah,
Oh my goodness.
yeah.
Yeah.
But again, that's treating a number. Well, it doesn't mean anything unless it's causing problems, right? Yeah. Well, eosinophils often don't cause any problems, but when they get high enough, they can start getting into the other organs.
So the indicator, I mean, am I wrong in saying to her, you look wonderful, you feel wonderful? She wants to go for further tests to see if she is transitioning into the more severe. And my feeling is you're doing well, you're feeling well, she has a normal, healthy life, she exercises, everything is well. Let's not look for trouble.
I agree with you. Well, I completely agree with you.
Am I wrong in
You're not wrong. I mean, the hope would be that if that is really the case, and the physician will say, listen, the same thing that you just said, but more quantify it. Say that, these are the parameters for which I would be concerned, and you don't meet any of those.
Yeah.
It's
Yeah.
one thing to say what you said. It's another thing to be objective about it and say,
Right.
these are the 5 things I would be worried about, and you don't have any of those 5 things. So don't worry.
Okay, great.
That would be nice
great.
if somebody would be able to say that to her. But
Yeah, she needs to hear that because she keeps thinking she's a walking time bomb.
yeah.
And it may not necessarily be.
No, I think the majority of patients with this there are a group of patients who really, and the patients that Dr. Gottlieb described on this trial were very sick patients.
Yeah.
The majority of patients don't qualify. I mean, I see 3 or 4 patients a month with systemic disease, but I may put only a couple patients a year on the trial, just because most of the patients are not sick enough, which is good.
Oh, that's a wonderful thing.
Yeah.
Yeah, absolutely. Thank you.
Sure.
Thank you.
So most patients, because of information available, are looking for the treatment and the prevention. And so when you're in the prevention mode, like feeling good.
Yeah.
See, my husband is sick. He's not feeling good. He couldn't make it today because
Right.
he's so sick. So, but in your case, and my husband says, wait, how can I prevent this
From getting worse.
from getting
Yeah.
worse? And so I understand
Yeah.
exactly.
So we don't know.
How she
Unfortunately, we
feels.
don't know whether this drug would do that,
Exactly.
and that's a separate question.
Right, and I think that's more
Yeah.
see where I'm on the
Yeah,
treatment
yeah.
side.
Yes.
That's
Preventive
a very good
side.
point. That's a very good point.
I'm taking leave it.
Yes.
My hematologist, he has never seen, I'm the first
Yeah.
hematologist.
So as you know, Gleevec doesn't work very well for this disorder.
Apparently not, but he said, oh, you have, after the bone marrow,
Right.
he said, oh, you have mastocytosis. I said, what is it? He said, it's a rare blood disease, it's incurable, but it is treatable, and here's the drug, leave it. What did I know? What do I know, And now I've been hearing all this other stuff about this mutation, the D816.
Yes.
Do I have, is it negative, positive? How do I know?
Yeah. Well, you have to specifically test for it. I mean, and the problem is this is a rare disease.
Shouldn't have shown up?
No,
No.
it's a specific test you have to send.
So he shouldn't have prescribed that, but whether it's negative or positive for that.
Well, he probably wouldn't have known where to test for it, or even to test for it.
But he's at least agrees with us that we should come up here
Yeah.
or to Mayo or something. What he said, obviously.
Where do you live?
In Orlando, Florida.
Okay.
So, he knows that
Yeah.
he's semi-blind,
Yeah.
at least.
It's a rare disease, and it's not one that's common. So it's and it's not one that's really taught well in medical school, and it's not one of these disorders that most oncology programs really are capable of dealing with. It's really a subspecialty.
And I'm sure they're overwhelmed with the true, cancer patients.
Well, I mean that's a different. That may or may not be. I mean, listen, if you're an oncologist in a community practice, you're seeing mostly lung cancer, breast cancer, colon cancer. That's just a reality. What I do, what Dr. Gottlieb and I do, we see patients with very rare diseases. I see mostly leukemia. He sees more of the chronic stuff. But this fits into that chronic stuff that is very rare. It's the rare of the rare, and it may be. You have to know what test to check for, and the c-KIT mutation is not something that most places are able to do. We don't do it. For example, I have to. We draw a sample and we have to send it to a specific lab to do it, and there's a couple around the country, but you have to know to test for it.
Anyway, he knows at least that he can't. He will manage down there.
Sure. Oh, that's the way most. Yeah.
And get retested up here.
That's the way most places are.
And then work with him. So that's what we're going to do. We spoke with Dr. Abrams.
Yeah.
Get him the number to make an appointment and come up.
Sure.
And get another referral. I hope we can carry the bone marrow slide. We don't have to do it other.
Well, we won't be able to do the c-KIT mutation otherwise. That has to be done on the bone. Well, no, I don't know your situation. But if one were to look at the c-KIT mutation, the only way to do that would be from the bone marrow. Yeah, but it may not be relevant. So, in other words, you could say, even if the c-KIT was positive, it's not going to change what we recommend. The only difference is that you're on Gleevec, and I'm not sure that makes a lot of sense.
He started with 100 milligrams.
Well, those cases that. Well, no. So it's complicated. The Gleevec doesn't tend to work for the KIT mutation at all, no matter what the dose. You don't know you have it. But what Gleevec was approved for was something that we discovered here, which is this one mutation, that FIP1L1 mutation. And you need you probably only need 50 milligrams of Gleevec. It doesn't come in 50 milligram pills, but you need a very, very low dose of Gleevec and that's why that dose that he started with is actually not an inappropriate dose for that disorder. Well, yeah, they do. Well, you look well, so hopefully.
So many people up here with mixture.
Yeah, it's so unpredictable.
Well, just let us know.
Unpredictable.
Yeah. So where's your husband being treated?
Well,
You're in Ohio, so.
when I'm in Ohio, our hematologist referred us to the Mayo Clinic.
Yeah.
So we're actually getting there next
Okay.
week. And I think we're fortunate because he did the legwork for us.
Yeah.
As soon as he made the diagnosis, we made the call. And he said that on our appointment, feel free to call if there's questions on the record. At least for that, I was grateful, but also the recognition that we needed something more.
Even among centers of excellence, there may be a difference of opinion. So don't be astonished if.
Oh, absolutely, absolutely. But I think he felt like we were looking for something more because my husband was really not feeling very good.
Yeah. Well, I'm sorry to hear. But let us know if we can help.
Oh, thank you.
Sure.
I have a monoproliferative neoplasm.
Yes. Oh, that's a. Yes. I'm sorry?
Why does that make you laugh?
No, but I've never seen a patient say that before.
That's
It's a mouthful.
Well, that's what I have.
Yes.
And the nurse maybe helps a bit with the thing.
Yes.
Yeah, that's what I have, and I'm just wondering where that goes. I'm on Gleevec. I've been on Gleevec because I had mastocytosis for a long time. I had a lot of gastrochrome. I don't know 500 milligrams 4 times a day. Gastrochrome. And all the usual stuff besides. And then last year they put me on Gleevec because I had a lot of symptoms. I had hyperesis and castrol and castrol and cells, which will continue, but it's not again with the mast cells. Eosinophils seem to be controlled with this, but I'm getting pretty severe mast cell symptoms still. So now they're talking about cladribine, and I'm looking for something that's maybe more hopeful for the future instead of just what I've had.
Right. Well, I mean, you heard from here. I mean, if you have, I mean, it's hard to be specific without knowing. And we talked about, you know, you had Barrow at Arthur. You know, if your symptoms warrant chemotherapy, your symptoms may allow you to participate in the clinical trial. So it's something to think about.
I've been on Hydrea, I've been on Gleevec, I've been on Gleevec for 2 years. But I increased to 800, I'm 800 milligrams a day.
Again, you know, Gleevec for eosinophilia, as you had mentioned, is usually a lower dose Gleevec. Gleevec doesn't seem to work for mastocytosis very well. So I would not be that enthusiastic of continuing that high dose of it. If it's going to work, it's going to work for a lower dose. And I don't think that you have the eosinophilia that's associated with hypereosinophil syndrome. It's probably due to the mastocytosis. And the question is, do you need treatment for your mastocytosis? And, you know, a lot of that's going to depend upon the bone marrow that you just had. And a lot of it's going to depend upon what other symptoms you're having and whether or not you would qualify for the study.
Diarrhea and vomiting and a lot of weight loss.
So a lot of that would have to be documented and to see whether or not you're eligible for the study. The study is ongoing. So I usually use cladribine for patients who I think need therapy, have aggressive disease, who have crossed that line in the sand and are not eligible for the study for whatever reason that would be. But I view them to be similar. So the patients that I would put on the study are the same patients I would give cladribine to.
Well, that's the one that Dr. Castells and Dr. Bidwell talked about now, is the cladribine. Learning about shows up in this most recent bone marrow and upper and lower GI endoscopy said both the same.
Well, you really should have Arthur give me a call
Yeah,
when he sees you.
I've seen him on Wednesday.
Yeah, I know him very well. He has my email. He can give me a call.
I'll tell him.
Yeah, yeah. Well, I have to. Well, you don't know. You have to see. You have to. You have all the tests and look at the records. You know, it's just in order to be eligible for a clinical trial, you have to have the disease, and then you have to have the symptoms we discussed. It's just a checkbox.
But you have to be in the right center, because you're a multi-center.
You're absolutely right, and so that was why I mentioned this. You know, the Mayo Clinic is often a naysayer in terms of some of these studies. They haven't participated for whatever reason, so you may get different opinions depending upon where you go. They really push.
Ask them, can you test me for this and tell me what
They do test. They'll do most of the work, you know. But the question is, they tend to put more patients on cladribine therapy than we would. For example, we would put patients on the clinical trial.
I read the paper on cladribine, and there was a very, very small trial, but there seems to be some good symptom response.
Oh, they're very good symptom responses. But it's chemotherapy.
Right, right, as opposed to this pop.
Yeah. There are, you know, yeah, it's chemotherapy. But it works. But it works.
Right. My name's Rochelle. My husband's Kevin Medley. He said, you hear
Just let me
from
know
me,
if
I will remind you that
Yes.
you called us.
I'll remember.
If we ever go that route.
Yeah, just let me know.
And what I do too is I'll mention to our hematologist your center.
Yeah. Oh, they'll know. Yeah.
And he's, I think he has our best interest.
I'm sure he does. Yeah.
I believe how quickly he got it.
It's tough. Best of luck. Let me know if I can help you. What are you heading back tomorrow? So you're heading back tomorrow?
I'm heading back tomorrow and then flying in the morning.
So the Mayo. Okay. You'll be busy.
Packed week. The Mayo was horrible. This was once he was diagnosed, we said, oh, this one is hospital. This one, his symptoms is that, you know, he had unfortunately a surgery right lesion, and he was fine, and then it just. So that's why I was kind of curious. Is that a possibility that it says all of a sudden we're going. It wasn't that we're going to go with. Thinking that, oh, let's find out more about the disease. So, I learned a lot, and especially speaking to George and Dr. Guys, kind of and so
Most people don't know numbers very well.
so when you were going to, it was actually refreshing for me to hear when you say, this is such a small trial. Because you do know that the statisticians will ask for some.
Oh yeah.
Thousands of patients for you to review.
That's right.
I appreciate you going to the data.
My pleasure. My pleasure. So where are you getting cared for again? Orlando, Florida. Yeah, it's a big... No, Moffett. Oh, no, Moffitt's in Tampa. Moffitt's in Tampa.
Winter Park.
You can move whenever you like.
Winter Park.
Oh, I see. And what's your last name again?
Ewald. E-W-A-L.
All right, I'll keep a track on it.
Yeah. We're going to try and,
Just let me know.
my husband talked to he gave him the phone number
Yeah.
to call and make an appointment, and he said, tell whoever he speaks to that Dr. Aiken said I was approved to come up or something,
Sounds good.
got the good word or something, so.
Dr. Angel, well done talk today.
Oh, thank you
A very
very much.
complicated area. I'm an anesthesiologist, and I have a colleague with a very bizarre and unusual cancer 10 years ago in Saskatoon. And he's coming around to being unwell again.
Saskatoon.
You heard of Saskatoon?
I have heard of it.
Well, that's good. He's an anesthesiologist as well, and his wife's a physician, good friend of mine.
Is that where you
Could I
practice out
possibly
of?
I did do in the past. I used to be at the University of Saskatchewan. But could I please get a contact information, because this is a complicated
Sure.
enough problem that I think his hematologist would really delight.
I'd love to. Unfortunately, I have my card. Yeah.
Oh, do you?
Yeah.
Thank you, sir. It's a very rare one, and anyway, I know that's not anything to go on, but I will get more particulars because he's starting to crash again.
So I have my email
Yep.
and my office number,
Perfect.
fax, and everything there.
Thanks very much, Daniel. I like your analogy about the lights on, lights off. That's what kids do.
A few minutes. I have questions.
Thanks very much.
Thank you, sir. Have a safe trip back.
Getting a consensus.
Sure.
Yes, cutaneous started when I was pregnant with my second child, I was old, and then became systemic. I was diagnosed with systemic bone marrow involvement, yes. Right now, all my blood tests are
Okay. Well, that's good. Yeah. Right, we don't, yeah. No, I thought, yeah.
237 to 720.
Right.
And then back down again to 100 and something.
Yeah, I don't really follow those. Yeah.
And my doctor, who's a hematologist, says, I don't really know what this is.
Yep. Yep. So the significance of the number is this, is that if you look at the tryptase number, and we can do it either way. So let's say this is tryptase. And this is the number of mast cells. That there is a rough correlation, but it's all over. So there are patients with lots of mast cells, and the tryptase is a little bit lower than you expect. And there are patients with, lots of mast cells, and their tryptase is lower than you would expect, as you expect to be here. And there are patients with a high tryptase, but not a lot of mast cells. So the question is why? So there's a general relationship, but some patients will have their mast cells, if you have an acute reaction, you can have a little bit of mast cells what are called degranulate, and your tryptase will be much higher. It's not a perfect
The night
test.
before I went for my
Or the week
blood
before.
test, there was an episode where I was scratching.
or diarrhea or something. It could alter the test, and there's no way to control for that. And there may be drugs like steroids if you're on, or other drugs that stabilize the mast cells, probably, that stabilize mast cells that would decrease the tryptase. So, so although there's a general correlation, it's not perfect. And so what you would like to see, make a smaller map, is you would like to see all the dots going, around. And what you see is this. They're all over the place. So there's a general trend. Dr. Vallon showed that slide. And so this is why I usually check a tryptase every 6 months and not more frequently than that, because you can get very disturbing results. And so in 6 months I find to be a better trend. And I never act on it. Yeah, so that's very good. I just use it as a general follow, so that, and what I do is as I keep a record of it, so I can go back 10 years on some of my patients and say, well, the tryptase there was 10, and now it's routinely in the 100, realizing it's still going to vary. That's a trend that's probably more disease now than there was 10 years ago. No, not as far as we know.
Okay, so I shouldn't be worried.
You shouldn't worry at all.
I'm taking cataracts.
Yep.
I'm taking Sinclair, 1
Yeah, that's not going to do anything. That's just to stabilize, make sure you don't have that many itching.
Yeah, and I'm doing okay.
Yeah, you have an indolent. You have indolent, and this may never go to aggressive. Absolutely. Oh, absolutely, because you're not having symptoms. So in order to be aggressive, you have systemic. But in order to have aggressive versus indolent, it's depending on whether you have those symptoms. And if you don't have the symptoms, then by definition, you have indolent. So do I. But yeah, right. So that's probably more of the mast cell activation, because they're not mutually exclusive, right? You can have the mast cell activation syndrome and systemic mastocytosis together or alone. And so that symptoms that you're having may be related to the mast cells being activated, and not related to just having more mast cells.
Is there a test for mast cell activation?
Unfortunately, no.
And what are the specific criteria?
Well, just, Dr. Valance, like Dr. Aiken has said, the allergic reactions, patients who have, episodes of anaphylaxis, episodes of GI problems, episodes of rash, low blood pressure, things like that.
Well, I think I'm going to make an effort to come up here and
Sure.
Yep.
Okay, what's the story?
Sounds like he's doing the right thing. Yeah.
Go ahead.
Yeah, no, I agree. Yeah, that sounds good. My pleasure.
I don't know what
Hi.
to do with myself. I'm not
shoot,
reactive. I'm like hematology mess. This is great though, right?
Good. It's been fun.
All right, so PKC you don't think, right?
Well, I don't know your situation, but it doesn't sound like
You
it.
want to see my last bone marrow? It's
Well,
up
you
to
showed
you.
it to me.
Oh, I did?
Yeah.
All right. Yeah, I
The
get
PKC would only be useful if you're. I mean, there's no question about the diagnosis. I think the question is whether is the symptoms, and if you're not having symptoms, it's
bone
silly.
pain, pain, and I don't know what to do.
So I think one has to look into why the bone pain is. Is it because of fibrosis? And in which case, maybe the JAK2 inhibitor might be better. Is it because of the mast cells?
Dr. Duffy, we always talk about something and everything, but he's bringing me there for surgery. Because in my last surgery, I didn't do too good.
We should talk after you have your surgery, like I said.
He was telling me, and he's not like, he shuts his door and he's like, I'm asking you, please go see this guy. And then I did a stupid move and I ran off the Sloan. I called him, he goes, well, I told you, Dana, and then I spoke to a few people and they're like, Sloan isn't what it used to be, and it made... It was just a matter of convenience.
Sure.
I ran there and... I just don't want to get worse,
Well, I don't know that anybody has a magic.
I mean, I didn't have ET 2 years ago. My platelets were fine, and then all of a sudden, boom, and then Duffy, we're coming with the iron therapy, and maybe we got a shot, and the iron was fine.
Sure.
And, do you think maybe interferon, would that reduce fibrosis? I don't even want to take bone marrows.
So
interferon
has been used for the treatment of ET and for mastocytosis, and that might be something that, you have to be careful there's a certain form of interferon called pegylated interferon.
That's
Pegasus.
what I wanted. Is that good or?
Well, again, it depends on the situation. I mean, I'd have to do more work.
I hear you.
Yeah, I can't really make that.
I've had fish analysis. I'm like, you know, even when I called MD Anderson.
Switch to another group or take advantage of another.
So give me a call. Have Duffy give me a call, or I'll talk to you.
Yeah, well, I'm going to be up there in surgeries probably like by next week. He's
Good luck.
expediting it. Thanks.
Thank you.
Okay.
This is not really related to mast cell.
Okay.
I don't think. I happen to have Sjogren's.
Okay.
And I also have mast cell activation syndrome.
Yes.
I have had neutropenia and leukopenia for over 12 or 13 years, well before either was diagnosed.
How severe?
Well, it varies. Sometimes my white blood cell count is very rarely above 2.5.
Okay.
Very rarely. Occasionally it makes it up to 2.8, 2.9, but most of the time it sits around 2.1. My neutrophils usually stay just below, I want to say just below 2,000. Sometimes they drop down the doctor got scared because last year at one point they dropped down to almost 900. They came back up again to 15, and that's usually where they tend to sit. That's not, do mast cell diseases ever have those two components out of whack?
They do.
Because most people are thinking it's the Plaquenil and the Sjogren's.
Well,
but
so patients so the question I would ask is, have you had a bone marrow examination?
No.
So, so you have a lot of reasons to have low blood counts. So it is true that Sjogren's disease can cause leukopenia and neutropenia. It's also true that Plaquenil and other drugs like it can cause low blood counts, specifically leukopenia.
But I had it before I was on that medicine.
But that Sjogren's can cause that.
Right.
It's impossible to exclude other causes without looking at a marrow.
See, because they postponed doing that because I've been fortunate enough, besides constant sinus infections, not necessarily to get typical flus.
Right.
I do get bronchitis frequently, which is typical of the
sometimes the
Sjogren's
decision is made, listen, that the white counts are a little low, but they're not low enough that I'm going to, whatever I found, I wouldn't do anything for it. So I'm not going to do the bone marrow.
Right.
But, so to answer the question that you're asking, which is, what is the cause of my low blood counts, is impossible without looking at the marrow. And it is, but it is very common that patients with Sjogren's and other diseases like it will have low blood counts.
All right, so I should just not fuss then.
Yeah.
Okay. That's what I thought,
All
and that's
right.
what I've been doing, but just checking,
No
that's
problem.
all.
My pleasure.
Thank you.
Okay.
Yeah. Yes.
It's
So
like
now
whether it's worth
you got to
after.
convince us about doing the trial.
And actually, the more I heard Dr. Gottlieb in particular, it's like, do I really want to even consider it at this point in time?
I don't know if you're eligible. That's the thing.
Exactly. I don't know if I am.
She didn't have any of those C factors.
That she's only eligible.
Right.
Right.
And she still doesn't have any of those, where she's in any kind of those kind of stress things. The platelet levels, everything is.
My blood is pretty much.
So the blood counts are good.
The
Blood counts are good.
They're all.
I've been having a lot of pain and bloating here lately, but I don't think that the spleen
And no
is
malnutrition.
Nope.
So you're probably not eligible.
Right, and she wasn't eligible with Dr. Gottlieb.
Yeah.
And so we don't want to jump into something or even try if it's not eligible.
You
We
know,
don't wanna
because
waste
when
your
I
time
talked
either.
to Dr. Costello,
Well, you could
she
send it-
thought that
could
I
send-
would be
Yeah.
a candidate.
So
Right.
I'm happy to look over the records, save you a trip.
And that's what we'll do. We'll
Yeah.
have Dr. Costello, once she gets all the blood work back, she can send that all to you and send you the records.
The records is going to be very
I
important.
think the reason she thought that I might respond well is because I was on dasatinib for about a year and a half and responded very, very
She was
well.
one of those that did.
So we've been having this discussion here. So if you remember that when you have a clinical trial, there's a between symptoms and there's a curve, and you have to draw the line in the sand saying that patients on this side of the curve are eligible and patients on this side of the curve are not.
Right.
That doesn't mean that a patient here may not benefit or a patient up here. It's just that they're not
It's just
eligible.
that
Right, and so that's, I
you're
guess, our
doing
concern.
a
Maybe it'll-
limited,
No, it's
maybe-
just you're drawing a line in the sand.
Right.
Now, when drugs become available, then this line becomes very blurry.
Sure, sure.
Because you don't need, the drugs available.
It's an FDA approved drug.
Exactly.
Okay, so we've gotten basically, I just got tentative approval back from TRICARE that they'll cover the clinical trial for us. It'll all be up to you to decide if she's eligible.
Yeah,
because
so I'll take a look at the
but you
records.
know,
Okay.
but you
So
know,
I'll talk
I
to
haven't
Dr.
had a
Costello.
bone
Yeah, just have her
biopsy for a while.
fax over the medical records will be the key thing.
Right.
And if you, or you could just send it.
I have an
again.
email. I can send you. I have.
Well,
all the-
Dr. Costello's has.
She has everything, and she has the stuff from MD Anderson where she went through the clinical trials there. So she's been on the two.
I sent you by email though, right?
I do. I
yeah.
got it.
So
I've
just
done
send me
all
an
your-
email,
I'll
remind
send
me
it to you.
next week.
Yeah,
Sure.
it sounds to me like
I'll send Dr.
I'm
Costello an email.
on the other side of that line in the
Line.
sand.
She was
Yeah.
there, and it
That's a
hasn't
better
got-
line to be on.
It's true.
Well, that's true. I
That's what
don't
we're
want
saying.
to be
Well,
on
we
the
look at
side
the-
of the
we
line.
look
No,
at
but
the
think about
criteria.
but think about it this way. Listen. Right now, there's really no drugs available for this
That's it.
disease.
Right.
And so you need when you define a disease, you have the disease, but then you define the minimum or the minimum symptoms that one needs to be on the trial.
Right.
In order to get the drug, but that should lead to a very significant optimism. Look at all these new drugs. All these new drugs are being
Just
developed.
in the last few years.
And what's triggered us to do this, I'm sorry, to even think about this, because she had 2 more anaphylactic shock attacks, and we're saying, okay, because we hadn't done anything for 4 years after we came off of RAD 001
You notice it's
or
it's
we,
the,
I'm
yes,
with her,
But the dasatinib did such wonderful things for me that it took a long time to come back up to the
where
point
she is
where
now.
I am now.
So
And,
all of the tryptase levels, everything else is back to
And
where.
living in Hawaii, I have very minimal exposure to my triggers, which
Right.
are environmental
You've been there for a long
chemicals.
time, or
7 years.
7 years, and before that we lived in Colorado, and I was
Getting
just
sick all the
a
time.
mess. I was just an extreme mess. But now that I'm away from the chemicals, all these things that just send me right into anaphylaxis, I'm doing much
She's
better.
been doing pretty good. And so that's why we're
But
hesitant
we're watching this
to
tryptase
jump into
keep
another.
going. It's got this
saying how far
curve.
is it
So the
gonna
good,
go?
so the way I would phrase this is saying, listen, you have an issue that you don't need therapy for right now, and that the good news is that there's effective therapy down the road. There's no doubt this is going to get approved.
Right.
And I would be, and so there's effective therapy on the road.
Right.
And there's a lot of effective therapies on the road.
I think that the biggest change that I have seen since there's been more exposure to mastocytosis patients for doctors is that they're starting to understand it, and we're able to prevent, death and near-death experiences when we go to the emergency room.
Right.
That's not to be understated.
I've had
all
it
we got to
many
do is go
times.
to the emergency room, hand her the instructions that were developed because of Dr. Costello's and everything, and hand it to them, and they follow it to the letter, and she walks away.
Because
It's very important.
previous to that, I present with 104, 105 degree fever when I'm in anaphylaxis, and the first thing an emergency room doctor would say was, "Oh, she's got an infection," and they wouldn't treat the anaphylaxis properly.
Right. So, and having the drugs, knowing which drugs to avoid, which drugs to give, these are all very important things.
Oh,
So,
absolutely. It's made a huge
I was going to
difference.
try and get more of those pamphlets for my patients. But I usually get them from Dr. Costello's, but they're very important things. And this is the important things where patients can be their own advocates by knowing their disease. Because I can promise you, most emergency room physicians around the country have never even heard of mastocytosis.
Right. I used to carry with me. In fact, I still do. I have a pamphlet in there that I hand to them. Say, you want to learn about it? In your spare time. Here's what she's got that you're treating her for.
Well, and the response to either of us saying verbally what is wrong and what we need.
Right.
Won't listen to that.
But it's much better if we hand them
But if
something.
it's written down,
Yeah.
it's a Bible.
It's a Bible. It really does work.
Those are very important.
Yeah. So, and our point in the whole this thing of proceeding with trying to maybe get into the 412 program was trying to be just a little bit more proactive to not
Well,
get
I-
to the point where she's so sick that she's got to get into the
And
program.
that may be the way the drug is used in the future.
Yeah.
That very well may be the way the drug is used in the future. Maybe not the right, maybe this dose, maybe a lower dose, who knows?
Yeah.
But that's a next clinical trial.
The next clinical trial.
The clinical trial right now is to look at trying to get the drug approved.
Oh, okay. And then the next one will be trying lower dosage with.
Or even mast cell activation syndrome.
Okay. Okay.
Who knows?
She's got the huge bone marrow involvement. It's just that it hasn't got any of the at least identified. Maybe
which is good.
We don't know. Well, of course, we don't know if they've been looking at all the stuff in you, like you're talking about in the bone marrow.
That's true.
That shows if
But
there's
since
another
I
disease
don't have
there.
hematological
At least we don't think she does.
markers as far as, like showing liver
Yeah.
or spleen, I don't have any.
Anemia.
Right.
Any
The
of
only
those.
thing I'm showing right now is that I'm pre-diabetic,
Yeah. But
which
it's
we
not
believe
that
is
part.
from
Yeah.
the
Yeah.
prednisone.
Yeah.
I don't see why they.
Yeah. Okay. Well,
All right.
we'll get you
I'll
the
talk to you.
information anyway. I
Yeah,
appreciate that.
absolutely.
And we'll
It's a pleasure.
see. Maybe it'll
We'll
be there,
talk.
maybe it won't be.
We'll talk electronically.
Electronic is always a good
Okay,
thing.
Dr. Costello though did mention hydroxyurea.
Hydroxyurea. So hydroxyurea can decrease and control some of the cutaneous lesions.
The cutaneous stuff.
Yeah, it can also control some of the systemic disease, but it's clearly not a treatment for like what we're talking about here. We're trying to get rid of the some of the disease.
It doesn't.
It just
it
controls it.
And how about the side effects of that? Are there quite a few? No, not
Almost
really.
zero.
Almost zero.
Yeah.
So maybe
Oh.
that's another way to go
Yeah.
too, just to something to get rid of some of the.
Just so that I'm not
Hard for me to again
always
without looking at the
flushing.
records. Very
Right, and
impossible to
that's-
comment.
Yeah, it'd be nice
no,
not
that's
to be
okay.
always
You'll see all that
flushing
stuff.
and
It's
always
all
feeling
there.
sick.
She spent so much time at MD Anderson. We were living in Houston.
Yeah,
you
geez.
know, so.
I rather live in Boston.
Well, I think that's what our choice was. Do we want to go to Stanford? Well, yeah, that'd be okay, but
Stanford's nice.
I need to go down to the north and get cannolis.
Yeah, there you go.
That's the only
Thank
reason
you,
why I'm
guys.
here. Thank you.
Thank you.
Quick question.
Of course.
You can help me.
Try.
My
Thank you.
husband was he suffered a toxic reaction to fish last year.
Okay.
We traveled to Switzerland because on vacation where
Sure.
he grew up from, and there we went to this allergist immunologist the day before we left, and he said
In Switzerland.
In Switzerland,
Okay.
he said, I believe you have systemic mastocytosis because your tryptase level is 25. So I said, okay, thank you. I'll find a doctor when I go back
Yeah.
to DC, and that's where we live. And it took about 10 months to figure it out that he was right because with the tryptase alone, they're not going to. And so we
Tryptase
went,
at 25 is, as Dr. Valent said, 11 is usually normal, 11 or 12, 13. But, when you start getting above 20, that's one of the minor criteria.
Well, so we went to NIH. I got into NIH, and Dr. Wilson is our doctor there. I spent a week
Wyndham
there.
Wilson or?
Todd Wilson.
Oh, I don't know Todd.
Under Metcalf. And his bone marrow, his DA16B is negative, but his tryptase was tested by Dr. Schwartz's lab, and it's coming from his mast cells. And in the meantime, we've...
How much marrow disease does he have?
He said that was his negative.
It's negative.
Fine.
Okay, good.
His CD 25, 4, everything was fine.
Good.
But both of our daughters have gone through NIH, and they both have elevated tryptase of 20 and 28. They both suffer from exercise-induced anaphylaxia and physical hives. And they don't have. And my husband's father has a tryptase of 55. He had colon cancer, Hashimoto's. And his sister,
That's fascinating.
yes, his sister is in Italy in Parma. She has a tryptase of 22, negative DA16V, but she has fatty liver disease, enlarged spleen. I think one of her kidneys is enlarged, anemia, Hashimoto's, and
Oh my God.
Raynaud's.
Yeah.
And her son also has an elevated tryptase of 22. So it's just really strange if it's not supposed to be familial or genetic, or we don't have any of the genetic markers for. So is he mast cell activation or is he mastocytosis? And NIH, they're just like, well, he doesn't really fit either of those.
Well, he doesn't have systemic mastocytosis unless he has a marrow that has the disease or another organ. So we can say he doesn't have systemic, but and there are patients with mast cell activation syndrome who will have an elevated tryptase. I've never seen a familial component to it.
Isn't that crazy? And so, both of my youngest daughter, her blood looks worse, but she seems healthier. I mean, she has a positive ANA. Her IgEs are 2,000. She has elevated eosinophils, and she has asthma versus the older daughter who doesn't. So she goes into, and she has a severe peanut allergy. So she goes into.
So there are patients with eosinophilia who can have an elevated tryptase, and the question always is back and forth: is it the mast cells that's causing it, or the eosinophils? But it's not clear.
And so Human Genome Project has accepted him, and they're sequencing his whole DNA, but they need to find another family, similar blood markers.
I've never heard of one.
Yeah, and so. And his IgEs are also in the 10 to 15,000 range, and they don't know why either.
I'm sure they've looked at there's hyper IgE syndrome.
Yeah. So, and the youngest, or the oldest has 500 IgEs, the youngest is around 2,000. So it's just, it doesn't make sense, and
Well, I mean,
I know a lot of this disease doesn't make sense, and not one size fits all.
I mean, it's a semantic. I wouldn't say it doesn't make sense. I think our level of knowledge is not to the level. I mean, the human genome was just sequenced a few years ago. We don't know all the regulatory factors for everything. 10 years from now, we probably won't be having this discussion because you'll know everything. Well, maybe or maybe not.
I haven't cared if it's MCMD, LMNOP, whatever. Like, I know he responds to the H1, H2s, and he was non-functioning. I mean, literally didn't leave the house for 3 months, couldn't get out of bed, and he's fine.
The familial component is an interesting factor. I think that what you described in your husband is more mast cell activation syndrome. But I don't understand the familial component without having the for both hyper IgE syndrome or having a high IgE. I shouldn't say the hyper IgE syndrome.
I mean, but is it autoimmune disorders that are running concurrently with this mast cell activation?
I don't think that. Again, they're not thought to run together.
And my other question is, he's a patient, and he's also, so we were at NIH, and we also, I don't know, so it's just like, I need to get to Boston, so we came up, and he's a patient of Dr. Castell's. And I'm just questioning on whether I should do another bone marrow biopsy on him, or if I should get his GI.
We should probably look. I think the easy one is if he had a recent bone marrow, we should at least look at it up here to review it. Get the slides reviewed here.
But how do I do that? Does Dr. Castells have to ask Dr. I mean, we sign papers at NIH, and we also, our girls, they challenge them, put them into anaphylaxis state.
Dr. Castells could request the slides from the NCI.
And they have all their blood. They drew their blood while they were in anaphylaxis.
Actually, the pathologist is over here that would look at it for you.
And send it to him?
Yeah.
All right. I just want to get, and it's not like I want him further tested, and I don't want
we can look at that. So the reason I would start there, because it could be that the bone marrow is just not, the bone marrow is perfect.
I mean, do you know what kind of test they do at NIH?
No, just look.
As far as like the stains are different?
The same.
Same. Okay. All right. Just
yeah, the same. They're the same.
Well, I
just having somebody else look at it. Good luck.
Exactly. Thank you.
You're welcome.
Hey. I said, so you are on aggressive, right?
Yeah. Okay. You're right.
I was wondering, because everybody was saying it was really rare for systemic mastocytosis to turn into aggressive mastocytosis, but how rare is it? Do you know?
Yeah, so we don't know the percentage. I would say less than 10%. Okay. But that's a guess number.
And then I also wanted to know...
Maybe very much lower than that. The problem is that nobody has been keeping data on the number of patients with mastocytosis, cutaneous or systemic, and then following those patients longitudinally. So, we don't know the number.
Okay.
But I would say probably less, about 10%.
Okay. And then I was wondering, are patients who as a kid had cutaneous and transitioned into systemic, are they more likely to get aggressive?
More, again, not known, but they're clearly at risk for that. But it's not clear that, I can't quote you a number.
More risk?
More risk than who?
Just based off your experience. Like, people who transition from cutaneous to systemic, to transition to systemic to aggravate.
Right. So most adults, I know it's not the question you asked, but so it's much more common in adults than it is in kids. And I don't know that there's a database large enough to say that. So most kids who have cutaneous, they do not go into systemic.
Yes,
Dr. Allen said that. Right? No. So that's where most of the data is. For kids who go into systemic, they're clearly at risk of going into, because you have systemic. So if you have systemic, you're going to be at risk for developing aggressive.
But would you say it's the same risk?
I don't. Who just there's no data to say it would be any different.
So okay.
Yeah.
But I meant just off personal experience, not like I'm going to quote you.
Yeah, my personal experience would be anecdotal, though. Would be a handful of patients, and most of the patients, again, the majority of the patients, I would say 9 out of 10, just never go into aggressive, or I haven't followed them long enough, and maybe they will 10 years from now. But the answer is right now they haven't. So the majority of patients do not, but having systemic, going from cutaneous to systemic, it does put you at a slight risk. But it's one of those things that one can't control. So I think the risk is very low that you're going to have any problems, but it's hard to know.
Just wondering, because it was already in transition.
Yeah.
You can transition again more likely.
Not that I'm aware of.
Okay.
All right. Best of luck. I got.